I was trying to give everybody an opportunity to finish their thoughts and find what they think will be their seats for a while. I am the Reverend Carter Grimmett. I'm the pastor here at Nardin Park, and I'd like to welcome you to Nardin Park. One of the things that I am proud of here, that we have, in the past year or so, have opened our doors to the conversations of the community. We think it's important that the community have an opportunity to share with each other their concerns, to share with each other their thoughts, and to be able to meet in a place where they can respect a difference of opinion, but at the same time know that their opinion is respected. For all of you who have never been here before, I hope that this won't be your last time here. We plan on really keeping our doors open to all nonprofit organizations that have a means, or to offer them a means by which they can share in and with the community their concerns. Unfortunately, it's hard to find those spaces nowadays. And it's very difficult even for churches, because many churches don't want to be tattooed or identified with any particular group or movement. And that I can understand. But I still believe it is our responsibility to offer people a safe space to share whatever issues they need to share as a community, and do it in a very safe environment. So welcome here to Nardin Park. And it's my blessing that as you meet, you will be able to share ideas and come up with strategies that will help all of us live a better and healthier life here in this state, not just for ourselves, but for those who follow us in the future. With that being said, I'm going to back off now and tell all of you goodbye, because I'm on my way to another meeting, but I'm sure that you will enjoy your time here.
Good evening, everyone. So glad you could make it. Welcome, everyone. My name is Dale Milford. I'm the Associate Minister here at Nardin Park. And we have a number of speakers I hope will be clarifying a lot of questions. We're going to be using a lot of slides. And Bob, if you could, for me and for those who are following me, when I say slide, go to the next slide, and when I say okay, lose the slide and come back to the screen. So you could go back to the beginning now. The first slide. Right, that's where we're starting from. Okay. So lose the slide. Thanks a lot. So we're just setting up this discussion inside of a church, which has brought a number of times a number of people to pose the question, hold on, this is the house of the Lord. This isn't a place for politics. How often have you heard that? Well, my response to that is this is not a partisan issue. Rather, it is a social justice issue. Now, to give you a bit of background, in addition to my responsibilities here as Associate Minister, my other job is as organizer for Michigan United, whose logo you saw there at the beginning. I'm also serving at the same time at a state level for the Board of Justice for the Michigan Conference of the United Methodist Church. So, bridging off from that point, Actually, earlier this year, there was a quadrennial worldwide conference, or what's called the General Conference of the United Methodist Church. And at that quadrennial international meeting this spring, they endorsed, slide, a revised treatise, and that was known as the Revised Social Principles. Now, this is a very powerfully worded aspirational document to set the standards of what we aspire to as members of the community as well as members of our church. That's the word behind social principles, not just theological principles. So, if you could go to the next slide, I'd like to take a peek. I don't know if you can read it very well from where you are, but I'll read the beginning of page 35 of that document. We declare that all individuals under basic rights and freedoms, no matter their circumstances or social standing, are entitled to basic human rights and freedoms. These rights are grounded in God's gracious act of creation in Genesis 1:27, and they're revealed fully in Jesus' incarnation of divine love. As a church, we will work to protect these rights and freedoms within the church and to reform the structures of society to ensure that every human being can thrive. That's a broad scope of basic human rights. Now, then they get into specifics, and the very first specific in this social principles is, guess what? Healthcare. Next slide, please. Healthcare. It starts out by saying, we affirm healthcare as a basic human right. We, as a church, go out into the community and assert that healthcare is a basic human right, and vow to work toward expanded access to all forms of medical treatment, including preventative, therapeutic, palliative care. Half the world's population lack access to health care, and a growing number of people who do have access face increased medical expenses for themselves or their loved ones, pushing them toward poverty. To confront these painful realities, we urge United Methodists to join efforts aimed at creating systems, and that's what we're here about this evening, creating systems that provide comprehensive health protections for all. Healthcare as a human right also means that clinics, hospitals, and medical services and treatments must be accessible, affordable, and of good quality. They also must be made available when and where they are needed and provided on an equitable basis. Okay, end slide. So, as many of you know, the United Nations General Assembly is happening right now in New York. So the next thing I'd like to do is take a look at how well we in America are living up to the standards by that worldwide standard set by the United Methodist General Conference. Well, the numbers I'm going to quote to you now are directly from studies undertaken by one of the United Nations agencies. It's called the World Health Organization. So the first slide I'd like to show from their information draws international comparisons of healthcare between various countries. And I'm going to show you 3 slides of comparison. First is average lifespan. How many times have you heard people say, we have the finest healthcare in the world? Well, here's an empirical barometer to draw against that. Where do you think the United States, among Western nations, falls in this? If you can't read it, can you guess where the United States lies on that? Way at the bottom. Of course, I didn't mention one other thing. I was raised in Canada, so I'm biased. Okay, I'll admit my bias right at the outset there. But I take a look. Now, we're not as good as Japan, where their average life expectancy is almost 85 years of age. Canada is about halfway down there, and it's only 83, or I've actually seen more recent figures saying an average lifespan of 84. The United States, by comparison, is only ranked at the average lifespan of 79 years. Now you can do pushback, you can do estimations and go, oh, there's a whole number of reasons for that. But guess what? All the other countries have a whole bunch of different reasons too. It's just a very simple metric to compare where we are. And the another counter is, well, all those countries impoverished their budget in order to accomplish that and raise the quality of health care. Well, that doesn't hold true either. The next slide I'd like to show you is healthcare as an average percentage of the national gross domestic product. That is, all the things they produce, how much of that is represented in healthcare? Well, again, I'm biased. I'm going to go looking we're not as good as Israel, but I'm looking at Canada, again, my point by which I grew up. It's around 11% of the gross domestic product is spent on health care. And anybody want to guess who's the worst country in the world? Go.
United States.
Very good. Can you read the number that is implied by that? Somewhere between 18 and 20%, depending on the year and the metric. But it's so far above all the others, it's not worth quibbling about where you found it. So that is a huge difference as well. So let's take that down to a personal level. What does it cost, on the next slide, the average person? And there's one country that jumps way off the chart. Anybody want to guess what country that is?
United States.
Right. The average cost per person for health care in the United States, according to the World Health Organization, is over $12,000. And again, Canada's not perfect, but they're only a little over $6,000. So we're talking very, very similar demographics. We're talking similar climate. We're talking very similar socioeconomic norms in the two countries. But what's the biggest difference between the two of them? Canada enacted universal health care, Medicare for all, whatever you want to call it, in the 1960s. It took until about 1970 before it really took full effect. But you've just seen 3 charts that show the monumental impact by going in the direction that we're talking about this evening. Now, statistics. How many times have you heard statistics used to... my mother used to always say that figures don't lie, but liars can figure. And so there's always a way to tweak numbers so that they tell the story you want them to tell. So rather than drone on for too long, I'd like to tell you my personal story from lived experience. I put this into context first. Last year in Michigan, 60% of all personal bankruptcies were caused directly by healthcare costs. It's the number one reason for bankruptcy, but over half of all bankruptcies are directly caused by healthcare expenses. Now, back in 2009, I was one of them. And why did I have to declare bankruptcy? Well, I had 3 liver transplants over a 5-year span. In fact, I couldn't even get disability at first. I got turned down, despite the fact that I was about to have a liver transplant. I couldn't even get disability without the help of a lawyer. But heavens, I was lucky, and I'll tell you why I was lucky. I had enough knowledge to go that route that many don't avail themselves of. So all the co-pays, all the deductibles, all the uncovered expenses forced me as well into bankruptcy, regardless of even getting the disability. So this story is a very personal one for me. And as I mentioned earlier, having been raised in Ontario, Canada, this was a complete shock to my system. I wasn't ready for this kind of stuff because I'd grown up in a place where that kind of thing just doesn't happen. And I do have, by the way, a large extended family that I've drawn stories from, not just 2 or 3 people. I have 24 first cousins and their spouses on my mother's side alone. So trust me, I've heard enough story, and there's not one of them who would exchange their health card for American coverage. Trust me. Case in point, my own dear departed mother. Long before she passed away from a stroke at the age of 84, she experienced breast cancer at the age of 75. Now, you all heard the rhetoric about Canadian system that you have to wait forever. Well, I will admit to you that there are times when elective surgery, like knee surgery or hip surgery, is scheduled. It does take longer in Canada. I will admit that in a second. But when you have a situation that is life-concerning, never mind life-threatening, it moves as fast as any place. In fact, I'd put to you, you'd be hard put to find even in this much larger metropolitan area, a hospital that acts as quickly as what she experienced in the backcountry. Her PCP learned of her lump and referred her to an oncologist. How long did it take to set that up? Stat? 1 week. The oncologist was very concerned about, from what he perceived and heard, about metastasis. So he actually ordered a CAT scan, not just a biopsy, but a CAT scan, to be really assured. You know how long that took to book? 1 week. And when the results came back from that, there was such an alarm he had that it could, it was self-contained, so to speak, and he was afraid of it bursting into her system and metastasizing, that he ordered immediate surgery. That he actually had to wait a little longer for. 10 days. Tell me any story that you know of anybody in this #1 health center of the world who would have gotten any quicker turnarounds than what I've just described. It just doesn't happen. And it doesn't happen like that in Canada either. Oh, and by the way, the total cost for my mother, for the specialists, the imaging, the surgery, the pre, during, and post follow-up care, do you know how much she paid out of pocket for that? Bupkis. Not 1 penny. And by the way, do you know what the percentage also of Canadians who go bankrupt because of health care? Double Bupkis. It just doesn't happen. My last point, back in my marketing career, I was also a partner in an independent health insurance brokerage. Yes, I was in league with the devil before I became a pastor. Have you ever heard of the 80-20 rule? Well, if you know anybody at the insurance commissioner's office, the insurance carriers can only show 20% of the total premiums being devoted to the commissions and the multiple commissions and the tierage and all the administration at Blue Cross and Humana, whoever. But what that doesn't take into account is the administrative costs at the hospital. You add all of that up, the amount of time that they spend on administration of claims and denial of claims, finding a workaround to the denial of claims, and denied physicians, et cetera, there's easily another 20% added to that. So look at it this way. Out of your, let's say, $600 a month premium, between the administrative costs and the commission costs, about $240 of that is going to wasted administration and insurance premiums that we could eliminate without having a competitive sourcing out to nasty, terrible people like I was. I learned as a broker to trace up and down where the commissions went and where the regional offices got their cut and the national office got their cut and the supervisor of the field agents got their cut and the agent got their cut. And I realized when I examined all this that the insurance industry, when you think about it, is really nothing more than a glorified pyramid scheme. Can I hear an amen? And it's our job to examine alternatives to a pyramid scheme that in many other situations has been rendered against the law. Well, what's being done to us all right now, $240 out of $600 going to that wastage, should be against the law. Of course, that's just one person's perspective. Today, we have the good fortune of connecting on Zoom with the president of One Payer States. He'll give us an overview of federal legislation that's being worked on right now to address all of that. Do we have our speaker from Washington ready?
Yeah, I'm here, Pastor Dale. Do you hear me?
Very good. Now we just need to see you.
My video's on live on my end. Okay.
Give us a second. We're good. If you would like to introduce yourself and your track record, it would be greatly appreciated.
Yeah, absolutely. Terrific opening, Pastor Dale. Thank you for setting the table for the conversation. I'm sure most folks in the audience are aware of just how broken our healthcare system, if we want to call it that, is. And I've been in this fight for since I ran for U.S. Senate back in Pennsylvania in 2006. I've been leading initially Healthcare for All Pennsylvania. And then a few years into that work, I came to realize that we're going to need to win the economic argument. So I began to reach out to other state organizations that were working at adopting and working toward universal healthcare at the state level. And that brought Michigan and California into the mix. And then very quickly, I realized that there were numerous other states. So we actually had 21 state affiliates launching One Payer States in late 2009, 2010. And One Payer States is an organization that it came together for the purpose, again, of sharing ideas, boosting our morale, sharing ideas about what legislation might look like, organizing strategies, developing economic impact studies, and so forth. So we're 15 years old as One Payer States, but again, it grew out initially of the work I was doing with Healthcare for All Pennsylvania, and along the way in doing that economic development work, I was also the producer on a documentary that a lot of people may have seen, which is Fix It: Healthcare at the Tipping Point, which makes the economic argument. And I think fundamentally that's how we're going to win this in the political arena, is making the economic argument that this is beneficial to individuals, to families, to communities, to municipalities, to counties, to regions, to states, and to cross-border relations and interstate areas, as well as the nation. And so we're building at all levels as One Payer States. And by the way, when we say one payer, that's just another way of saying or relating the term single payer, just another way of saying it. But we use the term one payer because it's not off-putting. It doesn't trigger people who are scared often when they hear that term, single payer. So that's the reason that we use the term single or one payer. And it's been very beneficial in working the halls of Harrisburg, or the capital of Pennsylvania, as well as here in Washington, D.C., as well as numerous states where I've helped with lobbying work and education around this issue. So just a brief word on my personal background. Again, my name is Chuck Pinocchio. I'm president of One Payer States, and I'm the lead educator lobbyist here in Washington, D.C., the first dedicated lobbyist for single payer. The focus of our work is primarily on the State-Based Universal Healthcare Act, which has been introduced since 2015, first by Jim McDermott, then Pramila Jayapal, and now it's being carried by Representative Ro Khanna of California. Just 2 months ago, for the very first time, we had the bill introduced by a senator, Ed Markey, who introduced the bill along with Elizabeth Warren, also of Massachusetts, and Jeff Merkley of Oregon. So we're very excited that we have the bill in both chambers, and we're doing outreach to Republicans to get them to sign on with it as well. We can frame the bill, we can frame the legislation in a way that makes it very easy, frankly, for center-right politicians to get on board, because the legislation is revenue neutral, and it allows states to innovate. And from a more conservative perspective, the idea of state innovation should feel very comfortable. And so there's the path of least resistance. This is also speaks to our theory of change, which is how do we win? And so we have multiple states. We're now up to 25 states with, in some cases, many campaigns within each state. California has 7, for example, 7 statewide single payer organizations. So the work that we do is building, ultimately to get to the North Star, our ultimate goal, which is to get to national expanded and improved Medicare for all, what I call MFA plus, Medicare for all plus. And you'll note that Pramila Jayapal, who's carrying the national Medicare for all bill, was previously carrying the state-based Universal Health Care Act, of which she thinks the world. I mean, she really is very closely identified with that. And Bernie Sanders is also on record as saying that he thinks that it's more likely that we're going to get to national Medicare for all by first modeling it in 1 or more states. And the good news is that we have a number of states, including California, Oregon, Washington, Minnesota, Maine, New York, Massachusetts, which are really, and New York, which are very much leading the way in terms of getting close, perhaps 2, 3, 4 years in the case of most of those states. And so we want to get this state-based universal health care legislation passed as soon as possible. And that's our goal, actually, is to get this legislation passed in 2025. And we're working very closely, in fact, with Pramila Jayapal's office. She is the chair, as many of you know, of the Congressional Progressive Caucus. And we're working on framing language. We want to coordinate our campaigns at the state level and the national level as much as possible. We want to use language that is shared so that we become much smarter about how we speak to the legislation and what it actually does. So we'll use the language that it is pro-business, that it's pro-entrepreneur, it's pro-family, it's pro-community. Again, repetition. We even use the frame USA, which is patriotic, right? USA, which is universal, simple, and affordable. USA, universal, simple, and affordable. It's a great frame. And also, I was speaking with Pastor Dale earlier. I think one of the ways that we need to frame the problem with the existing system, which is driven by profiteering, it's driven by profit pursuit on Wall Street as well as Silicon Valley, is that it's an industry that's not based on for-profit. It's actually profit first, meaning that the profit making is baked into their entire process, so that they avoid paying medical costs wherever possible, right? So they avoid those. Anytime they actually pay for medical costs, they call it a medical loss. So the entire framing of this industry is completely bankrupt, but unfortunately it's legal. We live in a completely deregulated, unfortunately mostly deregulated capitalist system that wraps around our healthcare. So the question then is, how are we going to win? And that's really what I'd like to center most of the conversation on today. I should say from my personal story, I've been involved in this work now for over 50 years. I became very politicized in the year 1968, and I've been very active in the healthcare movement again since 2006, after running for and winning double digit, 10% of the vote in Pennsylvania, the seat now held by Bob Casey. But after that race was over, I landed on healthcare as I thought the issue that touches on most people's lives. But we're also very intentional in seeing our issue of healthcare as intersecting with all social justice issues. And this is part of our strategy, is that we need to connect with people who are working for housing, people who are working for food security, people who are working to overcome problems with policing, the climate emergency, education funding, and so forth. Reproductive rights, all these issues of social justice need to be thought of as co-equal. And once we are very intentional in how we engage with people, I think we're going to be able to be much more effective, because we're not large enough as it is to overcome the industry power that's constituted by what I call the 4 horsemen from hell. That's big insurance, that's big pharma, that's big hospitals, and that's the big medical device industry. So I'm going to flash up on the screen here just a couple things. How am I doing on time, Reverend Dale? Pastor Dale? About 5 minutes, a couple more minutes to go? Okay, I don't know if you can see this. I'm going to pop this up on the screen here. This is the legislation that we're running is House Bill 6270. And this is the Senate bill 4817. This is the House bill. I'll drop those links into the chat if I'm able to do that. I'll do that after the break. And then this is our homepage for the state work that we're doing. This is a map that if you go to onepayerstates.org, you can learn about what's happening in all the different states from California, Colorado, Connecticut, Florida, Hawaii, Maine, Maryland, Massachusetts, Michigan, Minnesota, all the way
Pardon the
down to the
interruption. Can you hear me? You
Yes,
didn't
yes, go
share.
ahead.
You have not shared.
Oh, I need to share the screen. I
You
am
need
so
to
sorry.
share the screen.
Okay, I go Zoom, and then I do share. My bad. Share. Here we go. There we go.
Now we're in business.
There we go. So this is the screen where you can learn more about what's happening in all the states. And the beauty of doing this is to learn from what other states are doing that's effective, that's ineffective, that seems to apply to the campaigns that you're working on. And right here is Michigan. So take a look at onepayerstates.org to learn more about the work that we're doing. And then I referenced a minute ago HR 6270, which is the House State-Based Universal Health Care Act, and then the Senate bill, which is S 4817. I'll drop those in the chat for simplicity purposes. And then I'm going to pop up on the screen here very quickly something that I'm happy to talk with people at greater length at another time that's appropriate. But this is the whole idea of strategy building to win. We have 16, it's a 16-point strategy document. And I'm just going to pop up the first one, and that is that the whole process of effective strategy building begins with radically visioning our success, actually seeing the success first, and then asking yourself, what did we do? Past tense, what did we do to win? And this whole concept of radical visioning leads then to an understanding that we need to reverse engineer what we're doing. We need to understand that the process has got to be understood in terms of defining what strategy is and isn't. We need to answer the questions of how we engaged with a self-analysis and other analysis of what we're dealing with, and then creating short-term, mid-term, and long-term goals, bring in new leadership, cultivate relationships, be very intentional in terms of your communication, internal and external, and so forth. So there's a lot that I can share with you at a lengthier opportunity, but I do want to just let you know that we think about these things. We're working on a clear strategy on how we win, really vital, and that does include, again, bringing Republicans who can be reached into the fight and get them working and supporting this legislation. So, and then the last thing I'm going to share with you all is basically an understanding of what state-based universal health care is about. This legislation. How much time have I got here, Pastor Dale? About a minute? Can I do that? All right. So just to say that what is SBUCA? This is the State-Based Universal Health Care Act. It's a bill right in the House and the Senate that provides a one-step waiver application process for states to access federal health care dollars that are needed to make state-based universal health care system a reality. And these waivers allow states to bypass various federal requirements that would otherwise prevent them from creating an innovative new program. And even though the waivers are already available for many federal programs, no procedure currently exists to divert healthcare dollars to a state fund, nor do any exist that would help states include self-insured employer plans in their unified system. And then this document, this one-page document goes on and talks about in more detail what it is, why the states need it, how it can be implemented, what the process is, and so forth. So I invite folks to go to onepayerstates.org to learn more about the work that we're doing in terms of our communications, in terms of building strategy, in terms of taking a look at the legislation and seeing how that we're working with the national Medicare for All community and supporting the work that they're doing, the bills that Pramila Jayapal and Bernie Sanders are carrying, but understanding that our theory of change is fundamentally based on the belief that states, multiple states, offer the opportunity to model at the state level what can be done at the national level, and to say that that's, as you said in the opening, Pastor Dale, that's in fact how Canada was able to get to national Medicare for all. It was through one province, Saskatchewan, Tommy Douglas, the leader of Saskatchewan, who's regarded as the George Washington of Canadian history. He is the individual who was able to model it in Saskatchewan. And then all the other provinces looked at what was happening there and they said, we want a piece of that. And so within a few short years, Canada was able then to create a national Medicare for all system. And we believe that that's the likely pathway that we're going to get it done here in the United States, considering all the money that's involved with the medical industry in a raid in Washington, D.C., and the money that and the constituents in the more progressive states that are in a position to model this legislation at the state level. So I'll stop there and open up for questions now, or I guess after all the presenters, and I hope I didn't exceed the time. Thank you so much, everybody.
Well, thank you so much for that national perspective. And now we have the opportunity of getting very much a Michigan perspective from a gentleman who had to drive quickly from Lansing to get here after a full day working with the legislator he's working with. Ryan Bartholomew is the legislative director for Michigan State Rep Kerry Rheingans, who is behind MyCares. If you'd like to come and explain how I improperly introduced you.
All right, hi everybody. I absolutely did just come from Lansing. They were only really in session one day this month, unfortunately, much to our chagrin, so they kind of had to jam-pack everything into today for all the votes they wanted to get done pretty much prior to the election, which is not what I would hope for, but this is what they decided to do. I had some slides. I don't know if they're up there. You can ask for the next slide. Oh, okay. Could I have the next or first slide? Well, while that's happening, as Pastor Dale said, hi, I'm Ryan Bartholomew. I'm the legislative director for State Representative Kerry Rheingans. She is the state representative representing the 47th district in Michigan, which encompasses the west side of Ann Arbor, western Washtenaw County, and into southeast Jackson County. She is the only legislator currently in Lansing with a master's of public health, which we think is a very valuable perspective. The representative and I both met at the Center for Health and Research Transformation. It's where we both worked. It's a health policy firm through Michigan Medicine like 5-6 years ago. And she has been dedicated to health policy related issues for 2 decades. Great. So now the slides are up. So the bill that we introduced, MyCare, HB 4893, was originally Yusuf Rabi's old bill, Yusuf Rabi being another Ann Arbor representative who was term limited out. He's not the first, though. I know I don't have it on the slides, but actually there was another Ann Arbor representative who introduced a single-payer bill in the 90s, believe it or not. So we are really proud of keeping with that tradition. So I wanted to do a little bit of table setting here. My slides are very wordy. I apologize about that. We're kind of data policy nerds, so forgive me for that. But as you can see here, 47% of American adults said in the last year that it was very or somewhat difficult to afford their healthcare costs. And 23% of them said that they or a family member had to cut their prescriptions in half in order to ration them, in order to make sure that they had some sort of medication. For the average Michigander in 2020, the average healthcare costs averaged around $10,000 per year per person. And roughly 500,000 Michiganders do not have health insurance as it stands. And this is set to increase a bit throughout the year as the public health emergency following the pandemic has ended. So a bunch of folks who are on Medicaid are slowly being kicked off. So we're going to see an uptick from April of 24 through April of 25 of people just not receiving Medicaid coverage any longer. So next slide, please. So what is MyCare? So as I said, MyCare is HB 4893. It would create a state-based single-payer healthcare system here in Michigan. And again, single payer system, no deductibles, no co-pays, no co-insurance, just receiving the health care that you need because health care is indeed a human right and not a privilege for those who can afford it. So next slide, please. So who is covered? How does MyCare work? Every Michigander will be covered. The only folks who are not going to be covered is new residents to Michigan, so they have to wait 6 months in order to be covered. This is really just to make sure that we're not seeing a giant influx of people right away that we can't help accommodate, and we just want to make sure that people who are getting covered under MyCare are Michigan residents who are set to be here in the long term. So MyCare, a big part of the bill, it's about 30 pages. It was introduced largely as a messaging bill from the start because Yousef Rabhi was in the minority at the time. They didn't really think that this was a bill that had potential of going anywhere. This is my boss's top priority. So this is something that we are planning on working on for a very long time. So we're continuing to add to it. But when we first got to Lansing in 2023, this was the first thing that my boss really wanted to put out there. So instead of working through some more of the details initially, we wanted to just straight reintroduce. A big part of the current MyCare bill, though, establishes a bipartisan board that really oversees a lot of the implementation. This board is housed within the State Department of Health and Human Services, and they do a lot of things like evaluation and some cost setting and whatnot. As was alluded to in the last presentation, a big chunk of the funding for MyCare would come from federal dollars. Currently, how that process works without Ro Khanna's bill is that we would urge so we would pass the legislation out of the House and the Senate, signed by the governor. And at that point, we would have the Department of Health and Human Services request, not necessarily be granted, waivers from the federal government in order to draw down those federal dollars to use in our shared MyCare pool of money that is distributed to pay for people's health care. A big sticking point, people will say, well, isn't this just government control of how medicine is practiced? It is not. It is not government control of the practice of medicine. What it is a single payer system. So it is the, sorry, would you mind having the slide? Thank you. So what it does, it just changes how services are paid for. So instead of going through the insurance companies, you would be granted MyCare coverage solely because you're a Michigan resident. What is nice too is that some people might say, well, this is great, but won't providers make less? No. Actually, quite the opposite. Most providers would actually see an increase in the amount of money that they make as the rates for most of what occurs in the MyCare system or through MyCare would be, providers would be paid 125% of what Medicare pays for services. So for several providers who see a mix of patients, if they see a lot of Medicaid patients, if they see some with private insurance, they're likely to see an increase in the amount of money that they make. So that's another argument that is just not valid. And really the primary savings are getting the corporate greed out of healthcare and really through administrative costs, which were spoken about. There several doctors, like even just small private practices have several staff members solely dedicated to just contracting back and forth with the health insurance companies and not, and in this circumstance, there would only be one organization that is the contractor. But as I think I have later, another argument that comes up with MyCare or just with the single payer healthcare system in general is just talking about the real human cost of those jobs. And in MyCare in particular, we have preferential hiring for all of those folks to be hired in to work for MyCare because obviously administrating this brand new system is going to take quite a few people to do. And so we would want to put those people, give them preferential treatment in hiring, and then also we would be providing funding for them to be retrained in other very needed fields if they would like. So next slide, please. Again, apologies for how wordy they are. So MyCare includes all medically necessary coverage, and you can see that this giant list of what we have in the bill, we believe if it is medically necessary. It is something that you should have. Just intuitively makes sense. And though I think what we would describe as medically necessary is something that the insurance companies may not often. We believe that the person who should be telling folks what they need is their doctor and not some bureaucrat who decided arbitrarily that the services that the doctor said is necessary for you is something that you shouldn't have. So you can see here primary care all the way down to hospice ambulance services. The way that ambulances are funded is also another fun thing in our country, largely private. That's why you get a giant bill if you ever use an ambulance. I just anecdotally, just speaking to Canadian friends, they wouldn't hesitate to call an ambulance. I know a lot of people, if they need one, might consider calling an Uber because it just ultimately would be cheaper. That's something that shouldn't happen in the wealthiest country in the world. So then the price of medical devices and prescription drugs as well are going to be tied to the rates that are negotiated by the VA. We think that we're just, we don't need to reinvent the wheel. The VA negotiates on behalf of what veterans should pay for these medical devices and prescription drugs, and we believe that that rate should be good enough for everyone. So next slide, please. So this sounds great, but wouldn't it be better at the federal level? I think that's the general theme of tonight, and the answer is unequivocally yes. This would be better at the federal level, but as you heard from our previous speaker, the states are where we're going to build the momentum in order to try and get the federal level to, the federal government to implement a Medicare for All type system. So a state-based system that has several issues that a federal system does not. Something that has come up a lot in conversation has been about snowbirds. So folks who live in Michigan for the majority of the year, but then go to a state like Arizona or Florida in the winter. What happens to that? They have coverage that they would have MyCare coverage that is distributed. The funds are distributed in Michigan, but how would that work in a state that doesn't have a single payer system? How would we contract with them? And that's an issue that we're trying to figure out. We would want to ensure that these other states wouldn't be trying to take advantage of MyCare, overcharging Michiganders for services in order to try and take more money out of our state. So that's, that is an issue that a lot of state-based programs run into when they're being developed. Again, the federal government has to greenlight our ability to even draw down federal dollars. We could pass MyCare tomorrow, but the federal government could say, well, we don't want you to draw down federal dollars this way, so okay, you're done. We think that we would have more success in Democratic administration, but God forbid we see a future Trump administration, and that is definitely off the table. So then also building up the fund is going to be a key to, this is an issue that Vermont had. Vermont did pass a state-based single-payer system, but ultimately they had to walk it back. We also understand that there's going to be a massive overutilization in the beginning, and that makes sense. There are a lot of people in this country that go without necessary health care because of cost. And if it doesn't cost them an arm and a leg, theoretically, they would go and seek that treatment. And we fully anticipate that. So an issue that we would have to work out is how to build up funds, and then, when can we start to distribute them? So right now we're kind of leaning towards maybe like a 3-year on-ramp period where we're saving up money in our MyCare fund before we start to distribute them out to make sure that the funds are available for people as they need them. But obviously the people of Michigan cannot wait. I think that is another theme of tonight. The people of this state, this country, cannot wait. We need universal health care now. Next slide, please. So what needs to happen for MyCare to go into effect? I've been alluding to a lot of this for a while. We just want to be honest with people that this is not something that we can do right away. This is going to be a fight, but this is a fight that is worth having. So first and foremost, MyCare needs to pass the House and the Senate and be signed by the governor. There are a lot of folks in elected positions that are not so keen to see something like this happen. especially when you look at Blue Cross Blue Shield of Michigan being one of the top donors to political campaigns in Lansing on both sides of the aisle. Not so keen. But we had the most co-sponsors we've ever had this time. We had 22 co-sponsors, so don't lose faith there. The Treasury needs to create the fund. MDHHS needs to apply for waivers. We need to amend ERISA for large employers. And then most importantly, and this is one that we're likely going to see happen in the coming years anyway for a myriad of reasons, but we need to change our state's constitution to allow our state's taxation system to be progressive. Right now, everyone in Michigan pays a flat tax. If you're a billionaire, you pay the same rate as a teacher for your state taxes. We believe that in order to have MyCare go into effect, the rich need to pay their fair share in order to build up the fund, and also that money could be utilized in a myriad, as I said, of other ways. So that's likely going to be a ballot initiative. Next slide, please. So takeaways. It would be less complicated and more efficient to have a federal Medicare for All type system. We all know this. The road to state-based single-payer healthcare system is a long one, but again, it's a fight worth having. Healthcare is a human right, not a privilege for those that can afford it. I think that's why we're all here tonight, is we all acknowledge that. No person in the wealthiest country in the world should go bankrupt for getting sick or delay needed care because of cost. That's outrageous. That should not happen. And as I said, and as my boss says, the new term limits in Michigan now are 12 years. This is the top issue for my boss. If it takes all 12 years of her term in Lansing fighting for this, it's what it's going to take. So we're going to be in this fight. We'd love for you to join us. We are working on developing a MyCare website for those who can get involved, but if you go to carriereingans.com, we have a tab about MyCare, and you can sign up and get updates and various things. We've been having town halls all over the state on this, promoting it all the way, from Ann Arbor, Lansing, all the way up to Marquette. We've had them all over the state, so stay tuned for that. We're going to keep having those, and we're going to keep spreading the word. So thank you very much for coming tonight, and we hope to see you in the fight for single-payer healthcare at the state level. Thank you.
Thank you very much for that presentation. I hope you're able to stay for the end and ask questions, because I know I have at least a half a dozen for you. But I'll defer to your questions first. One person I know probably have some questions, but he first has some comments to make, and that's Dr. David Apsey. He's here as a representative of the Physicians for a National Health Program. Dr. Apsey.
Good evening, everybody. Thanks for coming. I'm so happy to see so many people in agreement that we need a federal single-payer health care program. John Conyers said it the right way. He introduced H.R. 676 for 14 sessions in the federal Congress. Did not get it passed, but it picked up to 115 or so sponsors in the House. Bernie Sanders had the corollary bill in the Senate. It did not get passed because of deadlock in Congress. But the thing is, it's still the simplest, best way to get there. And I'm happy to see that all the advocates for single payer in Michigan and other places have recognized that we have an inalienable right to health care, and that we need health care. It supports everything else we do in our life, including just like food, water, and shelter do. This is just as essential. We have to learn to take care of our neighbors. Forgiveness and acceptance are the most important to meet these moral values, to provide health care for the country. We need an equal, high-quality system available on demand without co-pays, deductibles, or any cost to all those in need. Just like Pastor Dale said, his sister had a complicated cancer therapy, zero copay. There's not one medical bankruptcy in Canada. That's our neighbor. The UAW has also settled their strike with the big three. I think it was it last year, in one day, where the UAW in the United States, it took them 30 days to settle with their stand-up strikes, which was, an innovative method. It still took them 30 days, and the UAW in Canada was all over in a day. So the best pathway forward that was worked well for national health care countries is a federal single-payer Medicare for all. That would be our corollary. Other places call it different. It's the same kind of a thing. Medicare trust funds in the country will accumulate all the funds. One fund pays all the claims out, has the lowest administration rate, it has the largest risk pool, which when any kind of a healthcare payer knows that to build the best model for taking care of the people with the lowest out-of-pocket overhead cost is to have the largest risk pool. Well, that's because you got to include all 330 million of us that live here, and you can throw in some tourists or whoever else too, almost free, as all national healthcare countries have found out. And you can go right into a hospital in Canada or France or wherever. If you just happen to have an acute emergency and you can get care, you can be in the hospital 5 days and you're going to go home and you're not going to get a bill. If you do, it's going to be very small. Nothing like here. To give a few words on all other pathways being suggested at this time, including the single state plans, but all other pathways being suggested at this time to achieve health care involve private health insurance. And they can be defined as going backwards. With private health insurance coverage covering more citizens costs more, and if we want to cut costs, we will have to cut people off of their care. And this is what's happened. We had CARES Act money come into Michigan. We got a lot of leftover CARES Act money, which is what the legislative aid has alluded to. And that when that money runs out, people are going to get kicked off their Medicaid. And I, as a provider myself, have been through this, several cycles of this, where people get their Medicaid, rush into the dental office, get their care. We do great care for them, take really good care of the families. They're very thankful, and then they get cut off. So, I've done just recently did a comprehensive prosthodontic reconstruction case for a lady who just absolutely would not have afforded it without her Medicaid coverage. I mean, she had a replacement teeth and a lot of teeth fixed, just free. She walked in, she had to pay, $100 for the whole case. It's a thousands of dollars case, maybe $7,000 to $10,000 case. $100 is not a big barrier for her. $7,000, not gonna happen. She just won't, she's not gonna have teeth. So anyway, to get a few words on the single state systems, these all involve private insurance. Again, as the legislative aid have mentioned to us, there are no state bills out of at least 66 since 2010 that have achieved universal health care in the state. All the bills collapsed over the funding models, all of them. Michigan, private insurance will continue to game the system each year, so more profit goes to the company and not for health care. This is, in fact, their legal and fiduciary duty as a corporation, is to maximize profit and distributions to shareholders. If you understand a corporate model of any corporation, it is to maximize profit, distribute the profits to the shareholders at the end of the year. Health insurance is no different. As a whole bunch of people said tonight, profits first, health care last. Private health finance causes suffering and early death, and it must be abolished from our system. Our MyCare bill plans to create a study committee to figure out how to assemble the funding. Correct me if I'm wrong, but the employer benefit plans governed by ERISA law. I saw him mention ERISA. You got to learn about this ERISA. You got to learn about these waivers if you want to understand how to fund health care. You have to have the largest risk pool, and you have to have the largest trust fund, and everybody eligible. That's 330 million all-American citizens. But if you're going to do it in Michigan, you're going to have to overcome federal health care law and in federal employee benefit law. CMS administrators are dictators who have absolute control and right to grant or deny waivers which would allow federal health care dollars to go to the state fund. That is not going to happen, has never happened. I'm not going to say it's not going to happen in the future because that would be wrong to predict that. You guys want to work hard on it? That's great. But that has never happened, and there's been at least 66 attempts to start doing this. All right? ERISA is a whole nother ballgame. ERISA law supersedes the state's right to make a law to collect funds. ERISA specifically states that no state can make a law to gather funds from an employee benefit plan unless they get a waiver from that benefit manager. Well, that means they're going to have to go to General Motors, Chrysler, Stellantis, Ford, whatever. All the big employer groups, they're going to have to literally negotiate those separately, and they are not going to get those waivers. That's going to take private, tax-free money that corporation is putting away for the health care and divert it to the state. You got to be kidding. If you think that's going to happen, that's more than a fight. That's an impossibility. So private insurance will live on. It will not be outlawed. It will not be eliminated. Only the power of a federal Medicare for All law can authorize the accumulation of funds by the IRS into the Medicare Trust Fund to pay health claims. Now, this was adjudicated recently with the Affordable Care Act. The Affordable Care Act came under heavy attack, and one of the attacks was from the Republican Party, mostly, was we want to abolish this thing because the IRS doesn't have the right to collect money for the Affordable Care, to fund the Affordable Care Act. Okay, so the Supreme Court ruled, oh yes they do. The Affordable Care Act is law of the land. This Congress passed it. The President signed it. The IRS absolutely has the right to collect the money, and that's the only reason we have the Affordable Care Act today, because you had to accumulate the trust fund monies. It went to Medicare fund, by the way. It went to the Medicare trust fund. It was paid out based on the new health care laws, no pre-existing conditions and various other things where more people were granted health care because of Affordable Care Act. It still never got to 100% universal, but it was much better. Okay, so we already know how well Medicare and Social Security work on the federal funding model. Medicare is the most experienced at paying for health care in the country, by far. They have a 2% overhead. Insurance companies have an average of 27 to 30% management costs, leaving far less money for health care. Pastor Dale says it's more like 40%. Okay. Somewhere between 27 and 40 is a lot of our money going out of a $3 trillion health care bill. I think it's near $3.5 trillion actually this year. So, multiply by 0.4 or 0.3, whichever it is, that's a huge amount of waste. We don't need the middleman that bad. We don't need them. We need to put the money all in one place and pay out the claims whenever the doctors make a claim. Medicare enforces equal quality health care nationwide and has a history of integrating Southern hospitals during the Civil Rights era. So it got people health care that previously could not have had it. So currently, rural hospitals in America, there are a lot of examples of the breakdown of American health care right now. I do anesthesia in my office. I put people to sleep and stuff, and so I have to buy, special drugs for that, for injectable drugs. Can't get them right now. I literally have had to cancel patients recently because I can't get them. These are simple, cheap, generic drugs, unavailable from U.S. suppliers. This is, and 5 years ago or so, I couldn't get IV bags. They're bags of salt water, for God's sakes. We couldn't get them. Yep. So currently, though, rural hospitals have been closing due to reduced profitability for their investment fund owners. Private hospitals will be abolished with Medicare for All. All necessary hospitals will stay open for preventive visits, prenatal care, and necessary health care. We need this care and we can afford it. And what John Conyers said, the message is, that we can try building all the coalitions in Congress. We absolutely need to do it. However, this thing's going to take a movement. We have different places where we can fight for things, and this healthcare is going to take a movement like the civil rights era movement, instead of just only up in the legislative arena. That's not going to happen. It's going to have to be a demand by the people, an enforceable demand by the people, to get this done. So that's all my. Everybody in, nobody out is the message for Medicare for all. So take care.
And now I'd like to introduce you to Dr. John Ross. He's a past president of the PNHP.
Yeah, Physicians for a National Health Program. If you want to go ahead and move the slides, you can. I knew we'd be talking tonight in a church, so I think the first slide is about the Golden Rule. If you look at all the religious traditions around the world, every single one of them talks about some form of, kind of a generic term would be reciprocity. Treat others as you would want them to treat you. And you can go down the list there if you want, but it's every major religious tradition and a lot of other obscure ones. I guess Baha'i, I heard Baha'i has the same, do unto others as you would have them do unto you. So the question really then becomes, who are we going to leave out? Who decides who we'd leave out? Right? Right now, we're not making that decision at all. There's no decision about it at all. And since I guess I'm in a Christian church, I'll quote the New Testament, which is Matthew 21:12. That's where Jesus, there aren't a lot of places where Jesus gets angry, but this is the one where he goes to the temple and the money changers are there and they're selling doves and other animals for sacrifice. And, he gets furious and he kicks their tables over and he knots up a cord and chases them out. But here's the important thing. When he's done, what does he do? He heals the sick. So we've got the money changers in the temple of medicine. That's where we're at right now. And again, the barriers that we're hearing about from our colleague who just spoke, they're money changer barriers. It's like moneyed interests are what is keeping us from having a reasonable healthcare system. So he may be right. We may need to get in the streets, but one of the problems is the people who need this the most have a tough time getting into those streets, right? People who are sick, people who are disabled, who are using healthcare services substantially. This is not going to be an easy thing for them, so we have to represent them. Want to go to the next slide, please? So there's a question here because for years and years what they've been saying is that we need some sort of market discipline on healthcare over and over again. Well, let's let the magic of the marketplace, look what it did for TVs, right? They got more spectacular and less expensive, and we should be able to do that for healthcare. Well, they've been out there buying it up. Huge private equity firms buying up doctor practices now, buying up hospital systems, all of them sucking money out rather than giving care. And healthcare is just not an ordinary product. The most expensive, wonderful stuff, nobody really wants it. You got to have it or die, right? You're going to buy or die, right? It's not like, oh gosh, yeah, please. Oh, open heart surgery's on sale, let me have 2. I mean, it's preposterous that the market can work on the most expensive and complex things. And we need to just recognize that market forces have failed over and over and over again. You want to go to the next slide, please? So what are the necessary conditions? So you can see you need to be able to easily enter or leave the marketplace. tough to do with a gunshot wound to the abdomen or a fractured femur. Pretty tough to leave the market. But no, thank you. I won't have you fix my hip. Well, then you'll die. So the most expensive serious illnesses are buy or die things. You're supposed to be sovereign as a consumer, but you aren't. Why? Because the information that you need to actually understand what you need when you're sick, unless you're a physician, and sometimes a super specialized physician, or dentist for that matter, you don't know what you need. You have to listen to them for their personal advice. So you're never really the buyer, right? You can be indirectly held to the costs of it, but you're never directly the buyer because you don't have the information that you need. And there's actually 2 or 3 Nobel Prize winners that looked at the economics here in healthcare of the failure of information. You don't have adequate information to make an intelligent choice. That's what you go to the doctor for. So you've got that breakdown in that area. That lack of information. And although we've heard a lot about profiteering in healthcare, that wasn't the tradition for long periods of time. And it's become more and more of it. I think most of the doctors that I knew over my career as a primary care internal medicine specialist taking care of adults with chronic illnesses, most of the doctors that I consulted with and everything, they weren't in it for the money. They made lots of money, but that wasn't their daily thought. That wasn't first in their mind all the time when they were trying to relieve human suffering. And I would say it was at least 90% of them had that in mind first. There's a few that were out there to make money, and that was their idea, but most of them were trying to relieve human suffering. And there need to be no natural monopolies or externalities. An externality is where you get your neighbor healthy. They don't get, like with TB, they don't give your children TB. That's called an externality, right? By treating your neighbor's children, you keep your children healthy. Vaccinations, there's a lot of that value in vaccinations, and we've been fighting about that whole thing. But there are also lots of monopolies, natural monopolies. One, say 4 or 5 family physician practice in maybe a town of 3,000 or 4,000. One hospital in a town of 10,000. One neurosurgical specialty group in a city of 70,000. These are all kind of natural monopolies that just make no sense to talk about the marketplace working, right? If you say you need a brain tumor removed and you're in a town that's only got one neurosurgical group and you go there and they say, well, I want your firstborn child. What are you supposed to say, right? I mean, the market is not going to work where there's these natural monopolies. You want to go ahead to the next slide? So you can keep clicking here because it's kind of a sequence. What this is it's a graph. Just click on through it. And what it's showing you is that those little skinny lines up at the top, those are all the other rich countries of the world. You've seen this data already, right? But focusing on the bottom line, that red line, that's us. Now, what's going up is your life expectancy. What's going out is the money we're spending. So you can see that we're spending more money going way, way out to the right, that's that red line going out, than all these other countries, and our life expectancy is worse. But more importantly, I want to point to HMO Act, Medicare Plus Choice, which is HMOs into Medicare, Medicare Advantage, which is Medicare HMOs on steroids, and you've got the Affordable Care Act, which brought all these sort of complexities to Medicaid. You've got the last thing here is called direct contracting entities. That's where hospitals and doctors can kind of become HMOs, but you don't know about it. You're in an HMO and you don't know it, okay, because they're behind the scenes doing it. And then lastly, something called REACH, which is those guys on steroids. So this is kind of what we've got here, right? We've got all these insurance companies, right? And for Medicare, but it could be any business could be doing this as well. Go ahead and hit the next one. They got to have contracts, right? Contract with all these different entities, these private entities. And then those private entities, hit the next one, have to have contract with doctors and hospitals. Now, that's just 1, 2, 3, 4, 5, 6 insurance companies. Imagine you're in a community like I was, where I could pull out a whole sheet of Greenbar and walk across my office entirely just listing the companies that my small little 4-man primary care practice was involved in. It's like a spider web. And all along the way, people are hiring people to chase money, hiring people to chase money. We had it in our office, the hospital had it in their office, the insurance companies have it, and now it's computers fighting with each other over who's going to pay the bill. You got artificial intelligence behind the scenes now. It isn't even human beings anymore. Go ahead to the next slide. So you got this fundamentally complicated issue. HMO-style tools, the prior authorizations, all this complexity of networks of doctors and what drugs you can have, what you can't. And they all want small networks because they want to control the physicians and control what they pay them. And they all want to shun the sick because sick people, like 10% of us generate 80% of the healthcare costs. So, I mean, it's a very small number of us are very ill, and that's just the way it is and always has been. So they get high overhead, high profits, and now we know, because we've been looking into some of the scams that the private insurers have been up to, that they're defrauding us. And they're paying huge fines for defrauding us. Some of the biggest fines, like the senator from Florida, was governor of Florida, got booted out of his hospital system for fraud and abuse. Made himself a 100 millionaire. Next slide, please. It's Rick Scott. I met Rick. It's like looking at an alligator. Anyway, so if you want to know the disease of the American healthcare system, it's its financial complexity. We could give them the money they're making in profits just to go away, and we would still have enough money to cover everybody. That's how much waste there is. This is just a classic Physicians for a National Health Program slide. This is since 1970. You can see, just like you saw those red marketplace ideas along the bottom of the other line, here's the administrative costs going up, up, up. That's the blue. The number of doctors, that yellow, okay, at the bottom. If you looked at the number of nurses, it would be a little bit below that yellow line. So we're just wasting money, incredibly on this sickness care non-system. And that's the administrative people. They're good people. They're doing work like anybody else. They come to every day and chase money. That's what they're supposed to do. That's what they were hired to do. I don't begrudge them. They didn't invent this crazy system. But what I can tell you, and this is the point of the talk that I'm giving, the marketplace is not going to cure it. Never, ever, ever. We've tried HMOs, ACOs, everything but Cheerios, right? And none of those things have reduced costs or improved quality. And the data is rock solid on all of that. So that emperor has no clothes. When they try to tell you that somehow the market is going to fix this, it ain't going to happen. It just isn't. Why don't you go to the next one? Just about done. So you heard Medicare 2%. Actually, I'll go to a slide after this one. It's probably going to be less than 2% overhead. So there's your Medicare card. Medicare only has to do one thing. You want to hit the next one? It just has to have a contract with doctors and hospitals. One contract. Actually, wouldn't even need much of a contract with most hospitals. The wisest thing would be to budget them. They all have to have budgets. I was a muckety-muck in my hospital down in Toledo. And, we had to create budgets every year, right? I was part of that budgetary process. We never knew whether we'd get the money to meet the budget because of the crazy quilt financing, right? But we had to make a budget. If you had an honest budget, you could just give us 1/12 of what we need to run the damn hospital every month. And then, have somebody oversee so we're not building palaces or, teak wood tables in the administrative offices or whatever. I mean, you could have some oversight. You could do it like we did papers in the 3rd grade, right? Pass to your right. Right? Let another hospital look and see if you're juicing the budget. It's not complicated. It's what they do all over these other rich countries is hospitals are budgeted. They're 80% of our healthcare dollars are invested in infrastructure to begin with, in the sense of their fixed costs. And before you can take care of one person with a complicated problem, you've got to have built the hospital, you got to have the ER to take that person in, you got to have the oxygen, you got to have the drugs, you got to have the IVs, the doctors trained, nurses trained, the beds there. It's all got to be there for the first person to get taken care of. That's 80% is already sunk. We all paid for all of it. What we don't do is do it in a simple and straightforward way. Go to the next one, please. So, Bernie Sanders and Pramila Jayapal, we've heard their names. Those are our heroes in the federal legislation. We actually got some hearings, and one of the people who was responsible for one of those hearings, John Yarmuth from Kentucky, asked for the CBO, the Congressional Budget Office, which is the scorekeeper for all these things, to actually look at what would be the financial effect. $400 billion. This is in 2020, December 2020. This is Trump's CBO. $400 billion in savings. That's enough to cover everybody who's not covered now, anybody who's in the country, with $40 billion left over, assuming that you let the doctors and hospitals keep all the administrative waste. They didn't even look at that. And the other thing they talked about, well, you know, if everybody suddenly had care, maybe there'd be longer waits in America. Well, guess what? We don't know how long people wait. Why? Because we've got almost 30 million people with no insurance at all. How do I average that in? Last I knew, you couldn't average infinity into anything, right? So we don't know how long we wait in America. What I can tell you is where we can measure wait times, they're about the same as those other countries that are all spending half of what we are with better outcomes. And the latest kind of revelation, hardly, every 2 years the Commonwealth Fund does something called Mirror, Mirror. Like mirror, mirror on the wall, who's the fairest of them all? It isn't us. Bottom, bottom, bottom. Every 2 years, bottom, bottom, bottom. Twice as expensive, worst outcomes. Sad truth, right? The emperor has no clothes. One more for me. So, yeah, we need improved expanded Medicare for all. That's the ideal solution. I happen to believe I will work at whatever level people want. I helped to create a universal system in Lucas County, okay, called CareNet, so that everybody could at least get primary care up to 200% of poverty before Obamacare. I will work at any level. I will work at the state level. I'm working in Ohio. I'm working here. I'm working nationally through PNHP. But I can't do it alone. I want to work where people want to work with me. You're all here. I'm working with you. When I go to my meetings in Ohio, I went all over Ohio. Deb knows. I dragged Deb into this whole mess. So it's USA. Universal makes it simple. Simple makes it affordable. And as was said, everybody in, nobody out. Let me hear you say that. Everybody in, nobody out. That's our demand. There is no change without a demand. That's what Frederick Douglass taught us when he was fighting slavery. There is no change without a demand. Everybody in, nobody out. We can't settle for anything less. We need to hold our representatives accountable for bringing that to us, and if they don't, we need to boot them out and get someone who will do it for us. So I'm done. Thanks.
Now, I know we are going a few minutes over time. We have one more speaker who was just referred to, Debbie Silverstein. She'll bring us some background details on PNHP. And then we still have all our speakers here. We'll gather up here for some question and answers. Now, Debbie, how long will you be taking?
Not long.
Good.
Most of what has been covered.
So Debbie will do a wrap-up on PNHP details, and we would strongly encourage you all to hang around for a few minutes afterwards so we can pose some questions to the speakers.
Yeah. Actually, I'm Bill Farmer, and I'm the chairperson of Michigan for Single Payer. So, well, I'm standing in for Bill tonight because he's recovering from COVID and just was not up to making the trip to come in here. I'm not really a part of PNHP, and I'm not a doctor, I'm a patient. So you're going to hear some stuff from the patient's point of view. Can we go to my first slide? And I'm going to be talking primarily about the Medicare for All Act in the federal Congress and just what it does contain. Most of the time it is patterned pretty much, or the state bills are patterned pretty much on the federal bills, so there's going to be some overlap, and I'm going to go through that quickly. Next slide. This is a serious attempt to diagram our healthcare system that was done after the passage of the Affordable Care Act. And if you look at it, the patient is in the lower right-hand corner, the physician is in the lower left-hand corner, but there is no direct route to get from the patient to the physician. You'll get eye strain before you'll find the way to get there. And, you know, and it's laughable, but despite all of that, people still fall through the cracks. People still are uninsured. People are even more underinsured. And that's why we have the bankruptcies we have in this country. Most people that go bankrupt have insurance. It's not the uninsured. Okay, this one, that's because of the last slide, that's why you get this, where you see that large amount of administrative waste. Here's an example. Duke University Hospital has 950 beds. They employ 1,600 billing clerks, almost 2 per bed, because that's what it takes. They estimate it costs them $99,000 a year to do the billing for one primary care physician. Next slide. This one builds on previous and improves on those bills. The biggest things to pay attention to is this bill has a prohibition against any future benefit cuts, and it also does some preparation for future healthcare emergencies. We were not prepared for COVID. We did not have the personal protection equipment that we needed. We didn't know what we were doing. And that's why we suffered more deaths per capita than other nations. Next. This one, so what is covered? All medically necessary care that you see that's free at point of service, no deductibles, co-pays, co-insurance, and so forth. But one of the things I want you to notice here, the eyes, the teeth, and the ears are now part of the human body, and they are covered too, the same as every other part. You know, why did we choose to leave them out? Why not the left foot? That would make just as much sense. So next slide. Okay. It includes everyone residing in the USA. You do not have to be a naturalized citizen. You don't have to be born here. When you add gatekeepers to keep people out, you add complexity and you add cost. If we're going to be really cost effective, we just allow everyone in. And it was alluded to that you can go to other countries and get care. I'm one that did that. When I thought I had broken my foot in France, when I was visiting my sister, I went to the emergency room thinking, oh my gosh, how much is this going to cost me? And when I went in and said, I think I broke my foot, their first question to me was, when you fell, madame, did you hit your head? I said, no. Did you hit your wrists, your knees, your hips? They never once asked me how I was going to pay for it. Because in France, I was a human being in need of care, not a financial resource to them, which is what I am here. Next slide. Okay, it is affordable for everyone. That's one of the basic reasons for doing this, because we eliminate all of the out-of-pocket expenses, we eliminate insurance company hassles, and we have no need to purchase additional insurance, supplemental insurance, which is one of the biggest complaints about Medicare. And that's a big, big improvement. Next. It's affordable for the nation. You know, we are picking up the costs for so many people, but it was the journalist T.R. Reid that said what we're doing is, you know, if they need a ride to work, instead of giving them a bag of bus tokens to take the bus to work, we're buying them a Cadillac. And when the gas runs out in the Cadillac, instead of filling the tank, we buy them another Cadillac. and that. So that's kind of the way we're doing it here. And with the, most of it is coming at the taxpayers' expenses, but it's actually all coming from you. It comes out of your pocket. Next. Global budgets for hospitals, and I like this one. Right now they chase the most lucrative procedures. In the last 2 years, I've had more CT scans and MRIs and ultrasounds and other imaging than I have had in the previous 69 years of my life. So yes, that's what they do. Everything you do, if you go in with a cold, oh, we need a CT scan. I finally told him, I said, you're on a diet, no more imaging. We're not doing it. So, they invest in the most profitable services and optimize the billing. Those wellness visits, they're looking to code you as a more complex patient so they can get a higher reimbursement rate. So the global budgets, they get their money. It doesn't matter how much you have. When I went to the hospital in France, I tried to pay, and they wouldn't let me. And I kept saying, but I don't live in France. I'm not part of your system. And they said, oh, madame, nobody pays. Because they had global budgeting. They didn't have 2 billing clerks per patient. Okay, next slide. It promotes health equity, and this is a critical thing. We don't have anything close to health equity in our system right now. We think keep in mind, equity is not equality. Equity is according to your needs, and the needs of some populations are different from the needs of other populations. We pretty much ignore our rural populations, and the hospital in the town where I live, there's only one hospital in town, and they recently decided they're going to drop the insurance plan that about 5,000 people in town have because they're too difficult to deal with. They fail to understand that their own billing department is too difficult to deal with. I have had to hang up on them several times because they get really nasty and mean. So I don't care. And my doctor said, well, they make us out to be the bad guys. I said, that's because you are. I said, you are acting like the bad guys here. I said, you know that half the town has this insurance and you're dropping it because you don't want to deal with them? I said, get real. So, go backwards, please. Can we go back one slide? Yeah. One of the things that we want to pay attention to in this is that we have protected populations, and we are preserving the VA, Indian Health, and TRICARE, and that's a concern many people have. And it's also, we're going to look at providing for those rural and underserved areas. That's what we saw happen in Canada when they passed their bill, is all of a sudden, medicine moved out to those areas. Next. So groups that are impacted by health disparities is pretty much everyone except rich old white guys. I think, that list is pretty, no, you're not discriminated against. I am. Okay. Next. The new benefits, we will have more benefits. For example, licensed marriage family therapists and mental health counselors. More protection because it bans prior authorizations and step therapy. And, if the hospital in my town wants to survive, they're going to take this insurance because everybody has it. And that. It does away with networks. You guys are all familiar with networks, right? They were the invention of the devil. More preparedness, and this is looking at being prepared for pandemics and endemics. And we're going to have another one. It's a virtual guarantee on that one. Okay, next. Okay, protected populations, TRICARE, veterans, and Native Americans. And this is an interesting one. Any changes require tribal consultation. So, the Native Americans have to have input into what is changed in that. So, okay, we can go on to the next. Displaced workers, 1% of the budget for the first 5 years. And we heard about that. I think Ryan mentioned that. and stuff. We do want to take care of those people because all of those administrators, we don't care about the CEOs and the presidents. They've made enough money. But the people that are chasing the money and filing the claims and paying the claims and that kind of thing, they're just like you and me. They go to work every day so that they can buy groceries, they can feed their kids, and keep a roof over their head. And so we don't want to take that away from them. Next. Okay. This is a 2-year implementation plan, which is kind of interesting. During the first year, current Medicare enrollees will be able to get all the enhanced benefits and coverage that the bill allows. In the second year, we auto-enroll infants at birth, and then we will enroll children up until through age 18, and then 55 and over becomes part of the plan. Also, there's a buy-in for that second year there, or that year after year 1, that people between 19 and 55 can buy into it. And after year 2, everyone's covered. So no one needs to buy in. We don't have to worry about it. Next. Okay, this is the buy-in option. Is available to residents 19 to 54, and the benefits will match the final Medicare for All legislation. It will be offered through the ACA. ACA qualified employers can offer it, and it's only going to be for that 1 year. When Medicare for All is universal, then the premiums and everything goes away. Next. Okay, why? And I mean, this is comparing commercial insurance to Medicare for All, and I think we know this. I'm not going to read the slide to you and stuff, but covers everybody, covers all parts of the body, free choice of doctor and hospital. That is one of the most important things. When I was negotiating health care benefits for my members, they didn't ask me what the specs of the policy were. They could have cared less who the insurance carrier was. Their only question was, can I keep my doctor? And that's a really important one. If you've got a decent relationship, a good relationship with your doctor, you need to cultivate that and stay there unless you're unhappy. Next. You can see it's no for everything under commercial insurance as far as improve health equity, reduce spending, and reduce costs for family. But yes to all of those. Next. Now this one I like. Medical costs are the tapeworm of American economic competitiveness. So, any of you ever had a tapeworm? I know one person that did, and they're pretty gross. But they are. They just eat and eat and eat. You know, the medical costs in the current system. We're not competitive in the global market. Well, we are, but at the cost of salaries for employees, benefits for employees, and pensions for employees. You know, it costs less to produce a car in Ontario, Canada than it does in Detroit, Michigan. And that's why Ontario, Canada, for a long time, and maybe still is, was the leading producer of automobiles in North America. They surpassed Michigan. They surpassed Ohio, which is an auto building state. So we need to think about that if we want our businesses, you know, to be successful and we want to have a strong economy. Next. Okay, here you see it's just us in Canada, our gross domestic product. I want to point out to you that when your gross healthcare is taking up that much of the gross domestic product, it's squeezing out other sectors of the economy. The more that we are spending on our own health care, the less money we have to buy groceries, to buy shoes, to go out to dinner, to go to the movies, you know, to do anything, take a vacation or whatever. So we're squeezing those sectors of the economy out. When I fell and broke my hip, the hospital was in network, but nobody that worked inside of it was. And they all worked for the hospital. They were all hospital employees, but the hospital kept them out of network so that they could balance bill. I mean, it was a while before I could do any of those things. It was $7,000 out of pocket for me. So, now the top slide you see, that's kind of a reenactment of the first one you saw, the complicated one, and then you've got single payer which is a much simpler and efficient system. Next. In the end, it all comes out of your pocket. You pay for health care in many different ways. It is all coming from you. That's where the money comes. So you're going to have to decide how many ways you want to pay for it and how cost-effective you want to be. Next slide. So you can take it out of one pocket in taxes for a single-payer plan, and those taxes would be lower than what you're paying now. Or you can go out of the other pocket and you can continue to pay the co-pays, deductibles, co-insurance, and premiums, and the taxes on top of that. So it's a decision that you're going to have to make on how you want to pay for it, because you're going to pay for it one way or the other. And most of these slides came from Physicians for a National Health Program, so I want to thank them. But I also want to add on, we do have to engage in sustained public pressure to get our elected officials to do the right thing. And sustained is a big part of that. We can't just call them once on the phone and say, I'm in favor of this. You have to call them every week. You know, you guys have heard of Sherrod Brown? He's a senator from Ohio. It was his wife who told us, if you want something from an elected official, you've got to be the burr up their butt. You have to hound them until it is easier for them to give you what you want than to listen to you one more time. So we're going to take Connie's advice, Mrs. Brown's advice, and we need to be the burr up their butt. Thank you.
If you'd like to have a seat, and if our other speakers would like to come and join up on the stage, don't run away. We're still shy of 2 hours of start time, so we'll talk a few minutes to these representatives of different viewpoints who'd like to share a response to questions that have occurred to you. Hang on a second, I'll turn on their microphones too. Very good. And if you'd like to ask a question, feel free to come down to one of these mics, or I can even walk it out to you. I know one question that I had to do with, I've heard that there is virtually an alliance of the states who are trying to put together state coverage which will leverage federal coverage. How many states are very actively pursuing that on a cooperative level interstate?
So this is kind of in its infancy, so I can't really speak to too much of it yet. But my boss has been in some conversations with some folks in other states, and we actually had an event at the Ford School of Public Policy at U of M, I believe last week or the week before, where we had a representative from Ohio and someone who worked on Vermont's system to come and compare and contrast the various systems and their approaches. And it is our intention to try and coordinate in the next term some sort of drop of the state-based single-payer legislation coinciding with one another for all of the states to try and gain some national attention with that. But again, as I said, it's still in its infancy, so stay tuned. If you're paying attention to MyCare and other states, hopefully you'll see a bigger story in the year to come.
My question goes to the state plans. In 2005, I began working with John Conyers and went around the country. One of the places we went was Vermont. And we worked with them on getting the legislature, their two chambers, and they did pass it. And then the governor, who had said he was for it and even ran as part of his campaign, vetoed it, all because of cost. And the cost that has been talked about here is RISA, the RISA situation, where I understand you could probably get the federal Medicare, Medicaid dollars, number one, but you wouldn't be able to probably get the money from, let's take, for example, the big three. Because the big three would then have to carve out for Michigan that health care plan that they put in there just for Michigan. And they represent people all over the country. So they're not about ready to do that, because they buy it in volume. The other problem that you have is with the trust fund. Because the trust fund is already defined by law that all that money in there, and Dingell asked this question when it was first set up. What happens to that money? Well, it's the company's money and the retirees' money. So somehow, if the company was generous enough, they would give it to the retirees. But it ultimately would go back to them. So that becomes part of the problem with state plans that I see. The real design here is that and going back to the Vermont plan, there was a lady, she was kind of hippie type. Her name was Peggy. And she, when we were working on this in Vermont, she's noted, she said the governor will never sign it because they can't get the money, it won't work. Even though he ran on it and people were all excited, and we know it didn't work. They never got it. So one of the things I want to say is John Conyers, weeks after Martin Luther King died, put in for that to be a national holiday. It did not occur until the 90s. You had Reagan in office. Conyers said Reagan didn't even talk to him. He worked through the Bush vice president. And they were able to pass that, not because some politician up there said it. It was because the feeling in the country was this was right. Now, we know Arizona didn't jump in real quick, but suddenly they changed their mind. So that's our job, I believe, is to get out here, convince these people, and be the burr in the ass that Debbie's talking about to these politicians. Debbie Stabenow ought to be ashamed of herself. In 2008, she came to Region 1A and promised us that if we gave her the White House and the 2 chambers, she would bring us single payer. She never did. When we asked her about it, she said she's going to do it in increments. She's going to take care of SNAP first and this one. And we said to her, SNAP, that's for kids. What about the parents? We have to be a burr in their ass.
What was your question? Did you have a question?
My question is, how is it going to work?
So,
how's it going to work? I mean, you want us to work on it? I see this petition asking, and we're going right to the federal people to ask them.
So I would say that you bring up a lot of valid points. Again, I didn't say it would be easy. We know that the federal level would be the ideal place for this, but I don't know if you've seen Congress lately. A little dysfunctional. Now, Lansing has its problems, sure, but we believe that we have a better shot working on it in Lansing with folks who are term limited, who are not perpetually there, who are in office for as long as they really want to be, who will likely not move on it, being subject to a lot of, or being the beneficiary of a lot of dollars from healthcare companies. Now, again, that is a problem that we have in Michigan as well, but we do think that it is something that will be a bit easier to overcome given the inertia of Congress. I do want to say, though, that in terms of ERISA and a lot of things of that nature, what my boss often talks about is that union workers often negotiate health benefits. And we believe that, A, it's going to be less costly for companies like the Big Three to pay money into the MyCare Fund than do what they're doing now. but also B, that if this is good for union workers in particular, because if they don't have to negotiate over healthcare benefits, they can negotiate more in terms of salary and other benefits, which is what we'd ultimately like to see as well, that our union brothers and sisters are able to actually make the money that they deserve for all the hard work that they do. So again, it is a very complex thing to do, to redesign. You saw Deb's graphic of the healthcare system, to do this from the ground up. But we believe that we have to try at the state level, and even if it's unsuccessful, bringing the attention to this issue so that hopefully our higher up elected officials see that this is something that we cannot afford to wait on. I'm optimistic. My boss is optimistic. We wouldn't be in these jobs if we weren't. And we really appreciate feedback and comments like yours, and any effort from constituents and just the people of Michigan helping to make this a reality. But yeah, please do.
There are other benefits to working on a state-based program. First of all, it helps to educate the people that are involved. It gives us a way to come out and talk to people in the communities, but it also allows us to educate our elected officials at the state level, many of whom go on and at least try to get into the federal level of government. Right now, my state senator is running for U.S. Congress. It's up to us to educate them before they get there. And if we can get the momentum going in a state, if Michigan is agitating and coming close, New York, California, again, can get close and that type of thing, it puts the pressure on the feds to do something and stuff. You may not be able to pass a pure single-payer bill in a state, and you can come close to doing that. And maybe California needs to do that, and that would put the pressure on them. As far as Vermont goes, there was some background on that one. After that bill was passed, there was a whisper campaign against some of the leading proponents of that bill, who were then defeated for their next term in the state legislature. And the governor's race was so close it got thrown into the legislature, and he basically sold it down the river in order to get another term. And that comes out, that was probably more of the reason for it than anything else.
But again, also for the other shortcomings of Vermont's system, that's something that we are actively paying attention to. That's something that other states are actively paying attention to. And it is our hope, in coordination with other states, that we can also learn from one another and try and make the most the holistic best system for our own state that we can. And also, just speaking of risk pools, having 10 million people in a risk pool for the population of Michigan makes the risk very small. Blue Cross Blue Shield has the biggest risk pool in Michigan, and is nowhere near that. So it ultimately would be, as we know it to be, although we are going to have a study, we are in the process of trying to get a study commissioned for the state of Michigan specifically, but we have an inkling based on the CBO report and other states that it would be very beneficial for us, very cost-saving to implement a type of system here. Sorry, you have a question as well.
I basically had a comment. What about, the big three and those companies that are self-insured, right? Because they have to pay out of pocket for all the health care. So they're certainly not going to just turn around and give the employees back that money, right? I mean, it just doesn't work that way from what I've seen. But, those corporations that are self-insured, they should be behind this 100%. Now, with the big three, obviously you need to sell it to the UAW first, right? I don't know. What are your comments on that?
Maybe I'll chime in if I can. Just correct me if I'm wrong on this, but you've seen the graphs. If you were a business leader and you were letting that happen in your business, your board would fire you. If you could have 2% overhead to produce the same product instead of 15% overhead, you would get rid of people who didn't do that. So to me, I think the argument to the business leaders is, why are you allowing this to happen? How does this benefit you? You know, to have your workers less well cared for and to pay twice as much as every other country in the world. I mean, that's on you. You're supposed to be the sharp economic pencil people. WTF, as they say, you know? I mean, to me, I'm going to talk to the Rotary on Monday in Toledo. And that's going to be my message. If you were the chairperson of this corporation, the United States of America, with these healthcare costs, and all your competitors had these healthcare costs, would you deserve firing? If I'm your board of directors, I'm going to think about that. So that's kind of my challenge to them, you're the business people. Is this good business? How does this good business?
I mean, it's like Mark Cuban with his health plus, the prescription thing, right? Negotiating just a set profit. How could we get him on board for promoting this?
Right. Well, again, so I think that's kind of where, to me, nobody here is a rocket scientist or an economist. You can look at that and just see how stupid it is. It's built into every product we try to sell overseas, is that excess healthcare premium. It's built into every single product because we're the people who get health insurance, your workers, so why are you doing such a stupid thing, American business people?
I did get a question that came in from somebody on the Zoom, and it was actually a request that Michigan for Single Payer has an action plan, and every single one of you and all the people who left as well are invited to join in with us. Now, there is a box back there of petitions, and we'd ask you to take one and get people to sign those petitions in support of single payer, and we're using those to talk with our legislators and to say, these are the people that support this. All of these, when we bring in stacks of thousands and thousands of signatures. So if you would please take one and help us get liberty, justice, and health care for all.
Amen. I think what's most important here is that we shouldn't have unrealistic expectations of what's going to happen next month, even next year. But I think we need to take into account that we're building a consensus, which leads me to one question I have with regard to PNHP. What is the consensus among medical professionals? In other words, should we be expecting pushback from them or them as an ally to this cause?
Yeah, kind of two answers, I guess, there. The first is that the biggest physician specialty group in America is the American College of Physicians. That's all the primary care internists like myself, but it's all the specialties of internal medicine. They support this. All right, the AMA does not, but that's a big organized group of physicians that are in favor of it. PNHP, when I first joined it, had 900 members, and we're at 22 or 3,000 members now. When I was president, I think we had about 10,000. So it's, and if you look at the next big block of caregivers, it's nurses. The largest nursing union in the country is National Nurses United. This is their issue because they recognize that they're caught in this squeeze too. The cost crunch to allow these profiteers to take their profits is causing them to suffer at the bedside because there aren't enough caregivers there at the bedside. They're all working to fill out the billing forms. So
excellent. We're going to have to wrap up now, so I'm going to ask, is there anybody who we haven't heard from yet who has a comment, a thought, a question? Bob, you had one more question that you wanted to offer before we wrap up. Okay.
You were wondering about the businesses and why don't they see this as a good performance or whatever. Well, when we began with Healthcare Now, Marilyn Clemens set up a meeting, her and Kay Tillow, and me and Conyers, and we were going to go to the board of directors of General Motors. We get there and we find out what? 3 people on that board are also on the board of Blue Cross Blue Shield. So these companies have this investment with each other, and we live in a class system, let's face it. Until we raise up and say we're tired of being killed, murdered by this healthcare system, it's going to continue. And the other story I have, I've taken care of people who have poor and very wealthy people. The people who live on trust fund, they don't care about the bills. They go to the best doctors right there in Boston, the best hospitals. Go to the women's hospital or this hospital, whoever is the best doctor. They don't care because there's a fund there to take care of them. We are not born that way. And until we recognize that we are together and fight against this evil of killing seniors by denials and delays, we're not going to make it.
Well, thank you all very much for your patience and staying with us this evening as best you can. And we really, really do appreciate all that we have been able to learn from you this evening. Thank you so much for your time, your effort, and your information. And if you have some friends who you wish had come along with you, who wasn't able to make it, this YouTube recording will stay forever on the Nardin Park UMC YouTube channel. So, and if you were registered for this, we're going to send you out a link to that to share with your friends. This recording will be, like I say, will be there forever. Do we have any last comments or just a wave goodbye from one of the speakers?
So long.
Farewell. Thanks again for your time. Everybody in and nobody out.
It's a human right, not a privilege.
Amen. Good night, everyone.